Definitely, as I mentioned, this is a real unmet need. The standard of care of these patients who relapse large cell lymphoma is to get salvage chemotherapy, radiotherapy, and stem cell transplant. And we know that actually 80% of the failures in large cell lymphoma occur earlier. And these patients do very poorly, about 10-20% long-term with standard radiotherapy and transplant. So historically, what we have tried to do is to try to see if we have a younger patient or donor to try to do an allo transplant. And very often we have a patient failing the disease just before the transplant take over to develop time to develop a graft versus lymphoma effect. So here we have a very sick set of patients that have no option with a very high response rate, very durable response, and across CAR T-cell different constructs. The response is long-term is about 30-40% of patients that are potentially cured. And we see very few relapse after 3 to 6 months. In addition, in our experience in Azuma, we had patients that actually had a PR at the first restaging, and then 20-30% of them, these patients ended up having a CR. So the next step is obviously trying to understand the predictors. We don't have a great idea, or the predictors who's going to do well, but also combination, and we are currently doing a trial, combination with checkpoint inhibitors and other molecules to try to improve the outcome.